Good to go.
In the next 20 minutes, I want to take you on a short tour of the just published 2026 guidelines. And then if there's time, and I think there will be, I want to share a little bit of the history of the GOLD guidelines, going back to 1998, how these GOLD guidelines have changed over the 26 years from the first GOLD report in 2001 till now, I think is a fascinating chapter in 21st century North American and European medicine. So next slide. And we have nothing to disclose. Next. So the 2026 GOLD guidelines. Now, some of you are very familiar with the GOLD guidelines, and some of you are maybe a little familiar. It's possible that there's someone here who's never heard of GOLD guidelines. I doubt it, but it is possible. So this GOLD 2026 report of 248 pages with 1,756 references, maybe more, because they have a whole long set of references at the end, but then they also often have bunches of references after each chapter, and I didn't look to see if there's any overlap between those sets. But this is what it looks like. You can just Google GOLD Guidelines 2026, and you get to their website and you can download it. And what I actually do is just have a folder on my computer of GOLD reports and download the latest one each year. And mostly I don't have time to look at it, but doing this gave me an opportunity to look at it more carefully. Next. So what is GOLD? Well, it stands for Global Initiative on Obstructive Lung Disease. It's important to note that this is a guideline for COPD. It does not apply to all chronic lung diseases. It's not a guideline for asthma. It's not a guideline for pulmonary fibrosis. It's not a guideline for black lung pneumoconiosis. This is for obstructive pulmonary disease. It's international. It actually, back in 1998, it did begin out of the National Heart, Lung, Blood Institute of NIH, was kind of where it was hatched, with some input from European colleagues. And over the years, that has changed somewhat, but it is an international effort. There is a GOLD Science Committee. When you look at who that science committee is, and they're listed at the very beginning of the report, it's 19 experts from 11 countries. But when you take a close look at what those 11 countries are, you see that while it's called the Global Initiative, it's really a North American, European group that does it, with then a few people from 3 other continents. A strength of it, in my opinion, has been annually updated. They update it every year. They do major revisions every few years, and I'll show you when these were in a second. But there is some effort to look at current evidence, the latest information that's out, like what David Wiseman put in the chat there, that kind of evidence, and to try to incorporate that into even the revisions that occur, or even the updates each year. And then the other thing I would say is GOLD is a wonderful resource for diagnosing, managing COPD, but it's not perfect. And Carl and I especially have had some conversations over the years about what's not perfect about it. But I think, it's definitely a glass 80% full, in my opinion, and that's what we're going to focus on here today. Next. So this is when the major revisions occurred. The first GOLD report came out in 2001, and then you can see about every 5 years, the science committee would do a major revision based on new evidence. And you can notice that in the last few years, that interval between major revisions has started to go down from 6 years to 4 years, and now this one is 3 years. And I don't know enough about their process, why that is, but new information coming out would be reason enough. Next. So this report, the GOLD 2026 report, here's the structure and outline of it. Chapter 1, definition and overview. Chapter 2, diagnosis, assessment, monitoring. Chapter 3, prevention and management. And you can see that that's the biggest chapter. That's the longest, the most pages dedicated to that. And that's why I put it in this, bolded it. Chapter 4, management of exacerbations. Chapter 5, COPD and Multimorbidity. When I look back over previous years, I think it was the 2023 actually had a chapter on COPD and COVID. We've matured, moved beyond that dreadful period in our lives, and so they don't have that chapter anymore. But if you're ever interested, you could go back and find that. And this year they have a brand new chapter, very short, as you can see, 8 pages, on AI and emerging technologies. And that's there. And then something new that they did is that they did evidence summaries, which they had not done before, at the end as appendices. And there's a long one on pharmacotherapy and a shorter one on non-pharmacological therapy. And I think I'll show you a little bit more about that in a second. Next slide. So same slide, but now I've just highlighted chapters 3 and chapter 4. For me as a clinician and for others who are clinicians, and I think for our respiratory therapists, I find this is where I'm going the most, because this is guiding my mostly pharmacologic therapy and a lot of our work with all of our lung patients, especially our COPD patients, has been juggling inhalers, just trying to prescribe the right ones, not to mention that people use them correctly or use them on schedule. But a lot of where we look is looking in these 2 chapters. And so the next few slides are going to focus on these chapters. One thing I want to say about the guidelines in general is I think they do a fantastic job highlighting important things for clinicians in tables and figures. And so there are a number of figures, many figures sprinkled out these guidelines, including in these chapters, that kind of summarizes the evidence for you in visual form and in flowcharts. And personally, I find those really helpful and great teaching tools. Next. Before you start trying to apply gold recommendations about pharmacotherapy or non-pharmacologic therapy for COPD, it's really important to make sure that the patient actually has COPD. And actually, Grace Ann is really great about coming to these echoes, and also about being willing to communicate back and forth about them. And frequently she's sending me stuff, asking me to check this out or look at that. So she follows the COPD literature, I can tell you. And when I saw this one, I shared it with her. And maybe, Grace Ann, you'll have a chance to comment on this later. But this is a really interesting study published in 2025 from China, from the National Respiratory Care Center of Excellence of China, which I think is in Guangzhou. But they used NHANES data. They were analyzing NHANES data. So they were analyzing US epidemiologic data, our data, to publish their story, published in Journal of Thoracic Disease. And they actually looked at a population sample of 24,000 people. And in that sample, they found 3,800 people who came with a clinical diagnosis of COPD. But they found that when they took that set of people, all 3,800 of those people had spirometry for NHANES, either pre or post. And they found that 1,000 of those did not meet criteria for COPD. So I would suggest to all of you that somewhere around 30% of the patients who in your EHRs have a diagnosis of COPD don't meet the spirometric criteria. And we've talked about this at this echo before. And to take a look, number one, you have a bunch of patients with a diagnosis of COPD who've never had a PFT. Try to make sure they get it. And number two, when you come across a patient with a diagnosis of COPD, look critically at the PFTs to see if they actually meet the diagnosis or not. Even if they don't, they probably are candidates for pulmonary rehab for other reasons. But still, I think it's important that we be aware that there's a relatively high prevalence of overdiagnosed COPD, and also there's that prevalence of underdiagnosed. And in this data, there was also good information about that. I didn't summarize it here. So make sure your patient really has COPD when you're applying the GOLD guidelines. Next. So you're going to see this slide 2 or 3 more times. So in chapter 3 of the 2026 GOLD guidelines, Prevention and Management of COPD. This is a key figure summarizing kind of clinical process, especially with respect to pharmacology, inhalers. And what you can see here, and a key thing is many of the people on this call are familiar with earlier versions of GOLD guidelines that had a ABCD clinical classification system. And that occurred in 2011, in the 2011 guidelines, and carried forward through 2017. Then in 2023, they basically separated clinical categories from spirometry. So the GOLD 3, GOLD 2 that Kate cited, that is a classification of spirometric severity. And that was used in deciding whether a person was in Group A, Group B, Group C, Group D, which was then used for selection of initial treatment. They stopped doing that in 2023. And this slide is identical to the 2023 slide. And as you look up in the corner there, you say this is figure 3.8. So figure number 8 in chapter 3. And in a minute or a little bit, I'll show you the difference between this slide in 2023 and this slide in 2026 look identical. But in a minute, I'll show you that there's a subtle difference. So what they did is they went from group A, B, C, D to just group A, B, and E. And if you look at this, you can tell that the way they do this is based on their exacerbation history, those gray boxes on the left, either 0 or 1 or more. So 1 or more gets you up in group E, which is the group for the most aggressive pharmacologic treatment at initial diagnosis. And then down below, you're in group A or B based on what your symptom score is. And they use the CAT score for that, or the MMRC. And I just want you to notice that this CAT score says CAAT instead of CAT. That's another recent change. It's just a change in name. Otherwise, the questions are exactly the same and the score is exactly the same. So you don't have to throw out your old CAT forms. You can keep using them, but don't be surprised that they're using a new name for it. And if you want to know more about it, you can go online and there's a nice YouTube video about that. But all they did is change the name. Partly they did that because they're finding that this COPD assessment test can and should be, they say, also applied for asthma. So instead of being limited to COPD, it can be used for a broader set of pulmonary diagnoses. Next.
Hey, Dan, one quick caveat. I think for the exacerbation history, it's 2 moderate in a year, which means you get outpatient steroids and antibiotics. And so severe, right? For that defined as hospitalization.
So you gave away one of the endings, Rob.
Oh,
that's what they changed from 23 to 26. And so I'll show you that in a second. Yeah, it's subtle. And you know, and I have a hard time not wondering sometimes the extent to which everybody on the science committee being on a speaker bureau contributes to this. Okay, so now now most of our patients, when they come to pulmonary rehab, are not initially diagnosed. They've had COPD for quite a while. And so this is the slide that they provide for clinicians about once you've tried your initial treatment. So for our primary care providers who have a newly diagnosed person who really has COPD spirometrically confirmed, they start them on the initial thing, and then we see them back in 3 months and 6 months and a year. And if they have persistent dyspnea or they've had 1 or more moderate severe exacerbations, figure 3.9 is guidance to us to how to change their treatment. And if you kind of look at the fine print on the gray side there, you'll see that they do mention that there's more to do than just prescribe more inhalers. It says implement or escalate non-pharmacological treatment. That means refer them to PR if you haven't already. And then they have some other medications that they mention. And of course, this might be where reduction surgery or separate valve could come in. Next. The other thing, okay, so then that's chapter 3. Chapter 4 is about exacerbations, and they say that they completely rewrote this chapter. But one thing about exacerbations, I want to say, especially again for RRTs, is that we kind of get in the habit of like prescribing antibiotics and steroids is kind of knee jerk for us with exacerbations. And this is a really good table when you have somebody with, oh, okay, they got another exacerbation, to always consider what else could be going on. And you can see the list here: bronchitis, heart failure, cardiovascular complications like MI or unstable angina or cardiac arrhythmia, pulmonary embolism, pneumonia, pneumothorax. And what I want to say about, so this is a good list to memorize and run in your head when you're dealing with someone with an exacerbation. But I also want to point out that most of the things on this, the diagnostic modalities on this list, some or all of them, are available to us in the primary care and the rural hospital setting. So I really see our respiratory therapists as being advocates for best care, and in some ways being coaches for our providers, at least the ones who are, are willing to listen to your suggestions. Next. What's new in 2026? What changed? Well, in chapter 3, there it is, Rob, at the top. They changed the ABE system from 2 or more exacerbations to 1. And it doesn't mean we have to exactly follow it, but that's how they changed it. That's how the science committee changed it, and it's subtle. There's a whole new section on disease activity. There's a whole new section on biologic therapies. Most of those are the TV ads you see all the time. And then they completely rewrote the chapter on exacerbations. They completely revised chapter 5 on multimorbidity, and they gave us a new chapter on AI that's very short. Next. Yeah, and Brandy, I see some of your comments here. So I just want to note the things in the chat. Rob mentioned we see a bunch of patients diagnosed with COPD and never had PFT, right? And there's a whole lot of reasons for that we could talk about. Brandy says, I'm in primary care and it happens a lot here too, right? And Allison, I see patients all the time who smoke and have a respiratory infection and automatically get told they're having a COPD exacerbation. Allison, when we get through here, I'd love to hear you say a little bit more about that. Okay, so initial inhaler treatment. So I put this slide up to show you exactly how it changed from 2023 to 2026. You got it? So the gray boxes in 2023, like you said, Rob, say 2 or more and mention hospitalization, and the gray boxes in 2026 eliminate hospitalization and change the bottom box to 0 and the top box to 1. And we could talk a lot about that, but I just want you to notice that happened. Next. And then I just wanted you to see these appendices they did on pharmacotherapy and non-pharmacological therapy. Again, because this is this is very much driven by pharmacology. There's a whole lot on pharmacotherapy, and there's not that much on non-pharmacological therapy. And when you look on the right side, non-pharmacological therapy, pulmonary rehab gets about 2 pages, and I'll show you one of the figures in a second. But this is what's in these appendices. But they're great. They're still great resources for good pharmacologic information and to think about, gee, what are other treatments beside inhalers that are available for these patients? Next. And especially, our emphasis, we keep coming back to this pulmonary rehab and COPD pyramid, that the most cost-effective things for COPD are the non-pharmacologic ones, and we know that many, many people get the pharmacologic and don't get the non-pharmacologic enough. Next. This is what the table in the evidence summary on non-pharmacologic methods. They do have this little table or figure A4.1, Appendix 4, number 1, And it lists evidence for these different ones, and there are references related to these. You can see the tiny little blue dots down there in the fine print. And I would really encourage our group that is involved in doing pulmonary rehab to go look at this and look at the evidence. And it's really worth even looking at some of the articles because they have more recent articles on new evidence for pulmonary rehab. And this is the kind of stuff that Grace Ann sends me all the time. Next.
Before we move on, Grace had a question.
Okay.
I don't know if it's a question so much as an observation, but this big shift in 2026 was related to the biologics that are now available for the type 2 inflammation for people with eosinophil, higher eosinophils. And that now that there's something to treat people with, I believe because of Dupixent and things like that for exacerbations, and there are even more now than Dupixent, a couple more have been approved, that motivated this change. And to go to those who are not frequent exacerbators, Ohtuvayre is so pricey that it's hardly available. But that is available for people who previously could only have a lama-laba. And if they can quell inflammation in general, and they can have access to Ohtuvayre, there are, of course, clinical trials that show that helps. So I do think this motivation for both of these changes was really due to the availability of new pharmacological agents.
Well, I think part of it too, and Dan, you highlighted it well, is, when these first guidelines came out, they were really just spirometry driven.
Yes.
I remember having conversations like this does not really capture the patient, what their symptoms are like. And, what research
Yeah.
subsequently showed and why these changes were made is particularly exacerbations. Those have the biggest impact on the trajectory of patients.
Yes.
If you have frequent exacerbations, you see quicker decline in lung function, you see worse mortality and morbidity.
Yes.
And that's what led to these changes over time. I think really understanding that there's more than one phenotype to COPD. And Grace Ann, from my recollection, I look at them when they came out. Now, you get on triple therapy, right? If with eosinophilia or persistent exacerbations with an ICS, but there's still a limited role, from what I understand there's not a ton of people with COPD who qualify for the biologic agents targeting eosinophilia. I think a trick some of our providers might use is talking about the COPD asthma overlap patients. And sometimes that's a way to get people qualified, particularly if they clearly have an asthma component.
Yeah, from what I have heard from colleagues as well as patients, is that it is easier to be qualified for the eosinophilic agent than it is to be qualified for Ohtuvayre. And much of this is related to cost, not whether or not they're eligible for it, but also, as you point out, nobody really knows what level of eosinophils is to be targeted. So they say over 300, but there's good evidence, I believe, that people with low accounts are also helped by use of those agents. So I think that's it's a moving target, as we have not pinned down a number really for those biologics. And I do agree with you that the overlap with asthma is significant. But I do feel that has been more available, Dupixent and its ilk, more available to patients than ensifedrin, than Ohtuvayre is. the cost is prohibitive. It's $3,000 a month for Ohtuvayre, and very few insurance companies will cover it.
Yeah, probably especially not in Africa and China.
Exactly. Well,
Okay, let's keep going. Next. Thank you, Grace Ann and Rob. That was great.
Thank you, Rob.
Next. We can skip this. Next. Okay, so here's my history slide. And it shows exactly what Rob was just mentioning, that in the 2001-2006 major revisions of the GOLD guidelines, the clinical assessment of severity linking to treatment was based on spirometry alone. And then, just as Rob described, he and many other pulmonologists, and there was science to this, realized that this was not taking into consideration different phenotypes, different clinical courses that people were having. So then they came up in 2011 with the ABCD classification, which continued to use spirometry severity, but incorporated, you can see across the bottom there, the MMRC2 and the CAT. And they kept on trying to use exacerbation history. But this ABCD classification, I think, was difficult for a lot of us because it had two y-axes. And sometimes people didn't fit into a category that easily. And then finally in 2023, what they did is they unlinked spirometric severity from the groups. And so then that was where you had the A, B, E with initially 0 to 1 at the bottom there, and then greater 2 or more, or 1 hospitalization. And I've already showed you the slight change in this from 23 to 2026. So that's kind of how GOLD changed over the course of the years. And in some ways, I think GOLD has done a great job of popularizing for clinicians what was going on scientifically and better understanding the biology of different phenotypes, the role of inflammation. But there is a snapshot of 21st century history of medicine in the treatment of COPD. Next. And I'm just going to end this. There it is. You've seen it multiple times. That's where we are now. And make sure your providers know this, and also figure 3.9, which is how to adjust treatment as they continue caring for people. Next. That's the end. Chantry and Kelly, we didn't leave much room. Yeah, for conversation. I know you got to wrap up, but thank you, everybody, and especially for everybody who showed up, and especially our GAD-PRC RTs. I'm proud of our great turnout. Carl.
Just real fast. Well, I did not realize until you said that there was a 2026 version, since we're all but 5 weeks into that year. But I pulled it up and looked at it, and I was one of the things that you and I have talked about before, but I'm always worried about with the whole GOLD guidelines is the people is not using low limit of normal diagnostically for people who have a little bit. And I give great credit to the people at GOLD as they continue to, I don't even know what the right word is, wordsmith and wordsmith and wordsmith and wordsmith, trying to find ways to treat people that don't really need it with mild COPD, especially young people. In the last version, the 2025 version, they just said we know we're going to treat people that don't need it who are young, and that's just a side effect of our approach. This time they don't even say that. It's amazing wordsmithing in the current thing. And I would encourage people to, the one thing that I think is important is if you don't clinically think they have the definition of COPD always still eludes me, but the pathologic definition. But if you don't think the person has COPD, if you think they have COPD, then these guidelines are awesome. I gotta say that first. Treating people who are hard to treat, the stepwise approach is just amazing. And I really support it. But if you don't think they have COPD, don't get sucked in because they have a FEV1 over FVC ratio of 0.69 and they're 24 years old. Just be very careful.
Thank you. Hey, David, you got a bottom line? You're muted. You're muted.